I'm now going to demonstrate for you my typical cervical spine evaluation. Now, every clinician may perform this slightly differently, and your examination may also be modified based on patient's subjective history. So let's assume my patient was in a distraction-based injury. What do we want to do? Initially go right to our C-spine rules. Let's assume that's all negative for the purposes of this video. Also, if my patient reported any radicular pain, myelopathic symptoms, or referred pain, we want to perform a full upper quarter screen. Let's also, for the purposes of this video, assume that that's negative as well. We then want to always assess for upper cervical spine instability tests, just as a preventative measure. And we'll go back on the plinth here. I'll first start with an alar ligament test. Good, that's negative. Then a sharp purser. Again, negative. And of course, VBI. Rotation, any pain with that?
No.
Okay, we want to perform a slight overpressure. Hold for 10 seconds. Let's say that's a negative test. And again, we do that to the opposite side. We then now want to go ahead and perform active range of motion of the cervical spine. So we'll start with upper cervical flexion. So I'll ask my patient to perform a chin tuck. Any pain associated with that?
No.
No pain. If there was pain, I would ask my patient to progress further into that pain and see if that reproduced his concordant symptoms. If it did, I would ask for repeated motions to see if that either increased or decreased his pain. So let's now go for upper cervical extension and ask our patient to stick out their neck. Any pain associated with that?
No.
No. Okay, good. We don't want to perform overpressures for upper cervical spine active range of motion. We'll then do lower cervical spine active range of motion and ask our patient to touch his chin to his chest. Any pain associated with that?
No.
No pain, so we want to perform an overpressure. Any pain with that?
No.
Okay. Let's do lower cervical extension, just like this. Any pain with that?
No.
Good. Any pain with that?
No, sir.
Still no pain. Okay, we got a happy patient. Let's perform some side flexion now. So I'm going to ask my patient to tilt his ear to his shoulder. He can choose which one he wants to start with. Any pain with that?
No.
Sorry about my looking at my back here, but I'm going to perform an overpressure. And the opposite side. Still no pain, overpressure. We then can perform rotation again. We already did this for VBI testing, but for the purpose of this video, we'll go ahead and do it again. Rotation, good, no pain, overpressure, other side, no pain, another overpressure. Okay, we then go ahead and do our passive technique. So we want to have our patient on the plinth.
On my back? Or
on your back, please, yeah. I'm going to raise him up for my body mechanics, of course. You mind if I get rid of this pillow for you?
Go for it.
All right. So I'm just raising him up because I'm going to have his head slip off the plinth so I can support him using a chin cradle grip. So come on back, slide him back to about T1. We'll start to assess the right side first. So what I'm going to do is first just take him into some side flexion here, all the way to the right, just like that. Now I can isolate each individual facet by moving up and down the articular pillar and assess side flexion at every cervical segment. I can then do the same thing for the left side. Good, just like that. We then can assess rotation. Head all the way to one side. Good. Head all the way to the other side. Take my patient all the way up into flexion. Good, now that I have the lower cervical spine locked up here, I can perform just like a flexion rotation test. Check out the upper cervical spine in this position. Good. Take him back into extension. Just like that. Any pain there?
No.
Also here, I can go back to my chin cradle grip and perform a chin tuck and some extension from the upper cervical spine. Any pain associated with any of that?
No.
All right. Next thing I want to do is have my patient position himself in prone. So I'm going to have you flip on your stomach. And I'm going to lower him down. I can now begin my passive accessory exam. So, once I get my patient lowered down, we want to expose the neck, making sure he's not wearing any of these beads around his neck like he is currently, but we'll ignore that. I apologize.
Oh boy.
Eric apologizes as well. So I then want to start with C2 and perform some CPAs. Using your dummy thumb, work all the way down, assess for concordancy. If you do reproduce pain, we want to move into that pain and mobilize, see if there's any reduction or increase in that pain. We can then perform UPAs on each side. I know this is hard to see what I'm doing here, but you can trust me, I'm doing UPAs. Go all the way down, and UPAs on the other side. Again, assessing for concordant symptoms. All the way down. That one hurt. If my patient reported any radicular pain or referred pain, I would then also try some UAPs. So I can have my patient flip over once again. And be gentle, as this is a sensitive technique. Come over and perform some gentle UAPs. This is a good technique to treat referred pain. So that's our accessory technique. We then can manual muscle test as well, but since there's limited parts to muscle test in the cervical spine, we don't have an extensive exam. But we do want to focus on is the anterior neck flexors, because these can often be weakened in a patient. So I'm going to ask Eric to tuck his chin, creating a double chin, and asking him to lift his head just off the mat. He should be able to maintain this position without firing the SCMs excessively and maintaining this slight fold in the neck like a double chin. And relax. We can now follow up this exam with any special tests that are highly specific to use as confirmatory special tests. And that is predominantly our full cervical spine examination rather.